everyone. We're so happy to have you in this session today. My name is Dr. Sharon Doby, and I'm a board member of the Scleroderma Research Foundation. I joined the board a number of years ago because as a mom and a physician, mom of a son who had scleroderma, I know that research is absolutely critical to finding better treatments and ultimately a cure for this disease. Before we begin, I want to mention the poll over on the left side of your screen. If you go there, you can tell us a little bit about yourself and read about other people who are also in this session. Now I'd like to introduce our next speaker, who's Dr. Monica Mukherjee. Dr. Monica Mukherjee is an associate professor of medicine at the Johns Hopkins University Division of Cardiology, where she serves as associate director of the echocardiography program at Johns Hopkins, and she's the medical director of the echocardiography lab at Johns Hopkins Bayview. Dr. Mukherjee has extensive clinical and research experience and receives funding from both the National Institutes of Health and the Department of Defense. With that, one last remember, don't forget to put in questions, and now I'll turn it over to Dr. Mukherjee.
Hello, my name is Monica Mukherjee, and today I will be speaking on scleroderma and the echocardiographic imaging of cardiopulmonary manifestations for the Scleroderma Research Foundation Patient Forum. I am an associate professor of medicine at Johns Hopkins University and a cardiologist. Thank you for having me today. I do not have any relevant disclosures. The objectives of my talk today will be to provide an overview of the cardiopulmonary manifestations in systemic sclerosis and the impact that it has on outcomes such as morbidity and mortality. I hope to define the role of some of these imaging techniques that we can help to classify some of the adverse complications of scleroderma, and then in the end propose a clinical algorithm that we use here at Hopkins that has really helped in the evaluation of these patients. So to start, as many of you know, scleroderma or systemic sclerosis is a complex heterogeneous autoimmune disease. It's characterized by a prominent vasculopathy, dysregulation and abnormalities of the immune system. There's tissue fibrosis that can affect multiple organs at different amounts, and there's a common association with Raynaud's phenomenon. And the survival rates are relatively good, but really depend on the degree of organ involvement. It's a relatively rare disorder. The annual U.S. incidence is about 250 to 280 per million. There's a very strong predilection for women. It's about 4 times greater in women than males, mostly presenting in the 4th and 5th decades of life. African Americans are at greater risk for having the diffuse subtype of disease, and the age and sex-adjusted mortality rates are greater than patients that don't have scleroderma. There are several different subtypes, but 2 main ones that we focus on. The first is limited scleroderma. Limited scleroderma is characterized by having a high incidence of anti-centromere antibody. About 70 to 80% of patients will be positive for anti-centromere. Patients with limited scleroderma tend to have a lot of telangiectasias, long-standing Raynaud's without some of the other typical features that we see of sclerodactyly, which is that tapering of the distal fingers. And here we see an example of someone with a lot of facial telangiectasias. This is someone who had long-standing Raynaud's and developed what's known as ischemic necrosis. And then overall, limited scleroderma patients have less severe organ involvement and a better prognosis, except for when pulmonary arterial hypertension develops later on in the disease. Diffuse scleroderma carries an overall worse prognosis, and notably, these patients will not be positive for anti-centromere antibody. About 30% will be positive for anti-topoisomerase. The onset of Raynaud's occurs within 1 year of the onset of skin changes, and those are characterized as truncal and thickening of the thorax. So the skin will become very thick, tight, and they'll also develop sclerodactyly. There is typically early and significant evidence of fibrosis of the organ tissues. And here we see a patient with scattered telangiectasias on the face. There is some typical skin changes of the face, including tightening of the oral opening. These are severe digital contractures and a patient with sclerodactyly, and they also have overlying loss of the pigment, which is known as vitiligo. And here we see a CT scan from a patient with diffuse scleroderma that has a lot of interstitial changes within the lung tissue itself and interstitial lung disease. Now, the pathogenesis of scleroderma is quite complex, it's multifactorial, and it's incompletely understood. What we do know is that there is a triad of vascular injury, immune dysfunction, and adverse connective tissue remodeling. And these are all interrelated processes that are reciprocally modulated. What that means is that the relative contribution to each of these processes in driving what a patient looks like varies greatly between patients, and that's why no two scleroderma patients look exactly alike. In terms of cardiac manifestations, there are a multitude of different cardiac manifestations that we can see. We can see arrhythmias, which are abnormalities in the electrical conduction of the heart. We can also see cardiomyopathy, which is a weakening of the heart muscle itself. We also can see changes in vascular function with Raynaud's phenomenon. Some patients will have abnormalities in their blood pressure with really high blood pressure versus really low blood pressure. And then very commonly, we see pulmonary vascular disease and pulmonary hypertension. We're also noticing that as scleroderma patients are living longer, that just like the general population that doesn't have scleroderma, our patients are developing the typical cardiovascular diseases that happen with aging. And that includes hypertension, high cholesterol, diabetes, coronary artery disease, and valve dysfunction. Scleroderma heart disease is quite common. Again, it can be primary from a primary problem with how the muscle is contracting. It can be secondary due to fibrosis of the cardiac tissue itself. It can be remodeling where the heart is kind of responding to increased pressure inside of the lungs. And again, this is confounded by having normal cardiovascular comorbidities like hypertension, diabetes, obesity, and aging. It's often under-recognized, and how we are recognizing it really depends on the screening techniques that are being used and whether or not patients are being seen by people who know that this is happening. Overall, it portends a not great prognosis, especially when pulmonary hypertension and right heart failure develop. So several years ago, one of the largest cohort studies of scleroderma is called the PHAROS study. And a retrospective review was performed over a 30-year time period. And what the study showed was that over 30 years, about 10 to 12% of patients developed pulmonary hypertension, which is elevated pressure inside of the lungs. And our group recently showed that pulmonary hypertension, which can occur in scleroderma across several of the different classes, that in some of the groups, we have done really, really well at improving mortality in scleroderma patients who have type 1 or class 1 pulmonary arterial hypertension. But we haven't done as well in improving the death rates in group 2 and group 3 scleroderma pulmonary hypertension. So what are these groups? Pulmonary hypertension is a condition where there is increased pressure inside of the lungs, and it's classified on whether it occurs before the capillary bed or after the capillary bed. So we call this pulmonary hypertension classes as precapillary or postcapillary. Pulmonary arterial hypertension is associated with scleroderma, and the annual prevalence is about 4.2% for all forms of pulmonary arterial hypertension. Pulmonary hypertension due to left heart disease is far more common across all populations, including scleroderma. This develops in scleroderma because of left heart problems with contractility, left heart problems with relaxation, problems with the valves, as well as congenital heart disease. Scleroderma patients can also develop pulmonary hypertension due to lung disease. So I showed you an example earlier of interstitial lung disease, which is fibrosis of the lung tissues. And this happens in scleroderma patients as well. There are two other forms of pulmonary hypertension, which can also occur, but not so much in scleroderma patients. For the sake of completion, group 4 is pulmonary hypertension due to obstruction of the lungs. So like pulmonary embolisms within the lung fields. And then group 5 is kind of a catch-all of pulmonary hypertension because of a multitude of issues. So the first 3 groups are the ones that are really impacting scleroderma patients. Now, back in the 70s, pulmonary hypertension was first defined in terms of guidelines, and it was always defined as having a mean pulmonary arterial pressure of over 25 when you perform what's known as a right heart catheterization. And what that is it's an invasive procedure where we go in with a catheter, usually from the neck, and we're measuring the pressure inside of each of the cardiac chambers. And it was always defined as having a mean PA pressure of greater than 25. But back in 2019, the World Symposium met and they said, listen, we have a wealth of epidemiologic evidence that patients who have a mean pulmonary arterial pressure of 21 to 24 are likely to develop pulmonary hypertension within 5 years. So shouldn't we be lowering this threshold of the definition to greater than 20 so that we can get to these patients earlier so they don't develop really bad pulmonary hypertension? And so as a result, that definition was lowered and it was changed. And the World Symposium is actually meeting again in June. And I think that they're probably going to keep the number exactly where it is, but maybe change one of the other parameters, which we'll talk about in a moment. And one of the most common diagnostic problems is determining, is it pre-capillary pulmonary hypertension or is it post-capillary, which we just talked about. So the new hemodynamic definition of pulmonary hypertension is if you have a mean PA pressure of greater than 20, but the pressure on the left side of your heart, so your wedge pressure, is normal. And in scleroderma, this is usually group 1 or group 3 disease. Post-capillary pulmonary hypertension means that the pressure inside of your lung is high, but the pressure inside of the left heart is also high, either because the left heart isn't contracting very well or it's not relaxing very well. And to make this distinction, you have to perform a right heart catheterization. But if you look at the algorithm for the diagnosis of pulmonary hypertension, it actually starts with echocardiography. And we have very specific recommendations through the American Society of Echo where we look at certain features. So this is an echo example of a patient with scleroderma that has very late stage pulmonary hypertension. This is the right heart. This is the left heart. And you can see here that the right heart is very, very enlarged. The right atrium is very enlarged. And the left side of the heart is really small and underfilled. So before that develops, there is an entire spectrum of remodeling that we can look at by echo. One of the earliest things that we see in pulmonary hypertension is that the RV will be normal in size. So again, this is your right side and your left side by echo. The right side of the heart will look generally normal in size, but be a little thick. And what the RV is trying to do is that the pressure in the lung is high. And so in order for the right ventricle to overcome that high pressure, it becomes a little thick. It's almost like being a bodybuilder, and it's trying to increase muscle mass to overcome that high pressure. But over time, what happens is that the RV is not like the LV. So we know of a lot of people who have normal high blood pressure in their aorta, and their LV gets really thick. The RV is unable to do that. So when there's high pressure inside of the lungs, after a while, it will start to fail and it becomes dilated and really big. And on echo, we're looking for these changes because we want to prevent this panel here, this panel C. We want to be jumping on patients in panel 1 and panel B before they develop right heart failure and symptoms of shortness of breath. So there are some limitations of using echo. A lot of people have always commented that the right ventricle is really difficult to use or difficult to visualize by echo. But actually, we've done a lot of studies to show that even with, those limitations, that a lot of the parameters that we see just with an echocardiogram are related to mortality in scleroderma. So the first is that if your right heart looks large, that is associated with heart failure and mortality. Some of the measures of how the right ventricle contracts also correlates with mortality. The rate of these changes is also related to developing pulmonary hypertension. And a lot of the measures that we see on echo also correlate with some of the functional tests that we do with pulmonary function testing and the 6-minute walk distance. And in fact, a lot of the screening modules that we use actually incorporate echo findings into the screening. So in the US, the largest or the best clinical tool that we have is known as the DETECT algorithm. And this was developed out of the University of Michigan, and it employs a 2-step decision tree in scleroderma patients who are at risk for pulmonary hypertension. So what it does is that it combines 8 variables, and it, based off of whether or not you have those 8 clinical variables, it determines whether or not you need an echo. Now here at Hopkins, we've kind of eliminated this first step, and we perform echocardiograms every single year on all of our patients. Based off of the echo findings within the DETECT model, it then you then get referred for a right heart invasive catheterization. And you can see here that the DETECT algorithm is really sensitive for ruling out pulmonary hypertension. So it is a good test for saying, yes, no, you don't have it. But there's a few limitations. First is that the DETECT algorithm used that old definition of pulmonary hypertension. And number 2, it excluded any scleroderma patient that had interstitial lung disease. Number 3 is that it relies on some echo features that are not always reported. And so in 2015, the European Society of Cardiology and the European Respiratory Society tried to improve these test characteristics into their screening algorithm by assigning probability of pulmonary hypertension. And you can see here that it's a great rule-in test, it's a good rule-out test, and it's sensitive and specific. But the features that they are looking for are that panel C that I showed you. They're looking for patients that have end-stage right heart failure to determine if they're high probability of PH. Why this matters is that there have been several studies that have shown that if you are very symptomatic and have impairments in your ability to walk or exert yourself, that is directly correlated with an increased risk of death. So if patients are developing really bad symptoms, that's already too late. By the time resting pulmonary hypertension develops and we become symptomatic, over 50 to 70% of the pulmonary vasculature has already been impacted. And so how do we use the techniques that we already have in clinical practice to improve outcomes? One of the things that we can do is called RV strain imaging. And what RV strain imaging does is that it takes an echocardiogram, and then we use a specialized software that's readily available to kind of measure how the heart is contracting. So we can look at the start of the cardiac cycle. Here, this segment is becoming smaller because it's contracting, so it's a more negative number peaking here at when the aortic valve closes, and then the tissue begins to relax. And we can apply these techniques to the LV and to the RV. So back in 2016, our group was one of the first to report that scleroderma patients have a very unique pattern of right ventricular contractility, where the base of their heart was working really, really hard, even in early stages of pulmonary hypertension or without pulmonary hypertension. We then looked to see what happens to scleroderma patients once they have pulmonary hypertension. Why is it that scleroderma patients can't handle pulmonary hypertension as well as some of the other non-scleroderma patient comparators? And what we found is that scleroderma patients, once they develop pulmonary hypertension, even at lower pressures, that their RV begins to fail. And we can detect that really well using that strain imaging that I just showed you. And there's a loss of the ability of their heart, that base, to really contract. When we gave scleroderma patients with pulmonary hypertension upfront combination therapies with medications, that segment actually improved. And we've also looked to see if strain can predict prognosis, and in fact, it does. At our center, we also perform exercise bicycle stress testing to determine what kind of scleroderma pulmonary hypertension we're dealing with. So a lot of patients come in with shortness of breath, and it's unclear what's driving the shortness of breath. Is it their interstitial lung disease? Is it the fact that they also have hypertension and diabetes? Is it the fact that we're missing group 1? And so it's really difficult to ascertain what's the primary driver. And so in those scenarios, exercise has been very helpful, coupled with strain imaging. So as I mentioned, scleroderma patients not only can develop group 1 pulmonary hypertension, they can also develop group 2. And group 2 is, again, an elevation in your pulmonary pressures because of a primary problem on the left side of your heart. So on the left side of your heart, you can either have a problem where the left ventricle is not contracting very well, or it's not relaxing very well. And that's known as heart failure with preserved ejection fraction, meaning it's not relaxing as well as it should. When we look at echoes of our scleroderma patients, you'll see that the right heart looks, mildly enlarged, but there's also some left heart disease. The left heart is a little bit thick. There's abnormal diastolic function, meaning abnormal relaxation. And then the pulmonary pressures are high, and they might have a leaky mitral valve or an aortic valve. What does scleroderma-associated heart failure with reduced ejection fraction look like? So this is usually less common. It's usually older men that have a lot of digital ulcerations, a lot of lung involvement, and typically have overlap disease, so scleroderma myocarditis or skeletal myositis. And here we see an example of a patient whose left heart is not moving well, the right heart is not moving well, and the right heart is so enlarged that the tricuspid leaflets aren't even coming together. Further complicating the picture is group 3 pulmonary hypertension. So it's the extraordinary problem of interstitial lung disease. Right now, interstitial lung disease is the most common cause of pulmonary fibrosis and death in scleroderma. Its prevalence is about 30%, and the 10-year mortality is around 40%. Most patients present with a long-standing, non-productive cough, shortness of breath, and then what we see on CT is a non-specific interstitial pneumonia pattern. And the standard therapy is usually a combination of immunosuppressants, particularly MMF or cyclophosphamide, as well as targeted biologic therapies. Here we see a CT example of with and without contrast from a 64-year-old patient with scleroderma. You can see that there's severe interstitial lung disease here with a lot of fibrosis of the lung tissue. The pulmonary artery is right here. It's also enlarged. And when compared to what the ascending aorta looks like, it's about twice the size. And so Again, very suggestive of group 3 pulmonary hypertension due to interstitial lung disease. On echo can be really difficult because of lung interference. We're putting a probe on someone's chest, and if the lungs are filled with fibrosis and air, it may be a little bit difficult to see the heart as well. And so a lot of times we'll take pictures from the subcostal or underneath the breastbone, and that can really help. The findings here are very similar to what we see in group 2. Usually the RV is not super dilated. It will have some increase in the muscle mass. And usually these patients, unless they also have hypertension and hyperlipidemia, obesity, and some of the standard risk factors, their left heart will look otherwise normal. So what about developing a clinical algorithm? What we do at Hopkins is a yearly EKG, yearly pulmonary function testing. If you're on medications for pulmonary hypertension, we do perform a 6-minute walk distance to measure improvement. Every single patient gets an echo. We also do an NT-proBNP and a uric acid. And we also measure what's known as patient-reported outcomes. So symptoms of shortness of breath. We're always trying to figure out whether what we see on an imaging parameter matches what a patient is feeling. That's extremely important to us, is to look at all of this as it relates to what a patient is feeling. And really, this approach has been at the forefront of changing survival rates through the employment of these really basic clinical screening and early detection techniques. As I showed you before, we have been able to demonstrate within our group a 60% improvement in mortality from pulmonary hypertension just from doing some of these measures. So in conclusion, really, scleroderma patients are at the forefront of understanding our management of cardiac involvement, not only in scleroderma, but it's a case study of how we should be approaching all rheumatologic conditions. And by providing precise and detailed information, imaging can really guide personalized medicine approaches. We're able to tailor treatment strategies to individual patients based on their specific disease characteristics and response to therapy. So yes, scleroderma is an autoimmune disease that is characterized by immune dysfunction and vasculopathy, tissue fibrosis, and pulmonary hypertension. RV failure is really hard to detect, but it's so important for us cardiologists who are partnering with pulmonary and rheumatology to report and identify any early signs that we're seeing and really report out, hey, someone's RV doesn't look normal, because they're relying on us and the patients are relying on us to identify them at an earlier stage of the disease. These imaging modalities have led to earlier diagnoses, treatment of PH, and we have improved clinical outcomes. So I do think that the future is very bright for scleroderma, and it starts with an awareness that this is happening, but we can do something about it. And with that, I will leave you with any time for questions. Thank you.
Well, thank you so much, Dr. Mukherjee. Your presentation was wonderful, and we have a lot of questions. So let's just get started, okay?
Great.
So the first question really has to do with screening. Do all centers do the kind of screening that you recommended in your talk? Should all patients be screened? And what should we do if we're getting our care at a center that doesn't routinely do the kind of screening that you recommended?
Yeah, so we really have noticed that with screening, we have improved early detection of heart disease and scleroderma. And so I can't emphasize enough how important screening is, because we're really picking up a lot of disease at an earlier stage that we would have missed. And so what I really recommend is that even if you are not at a major pulmonary hypertension center, that you have a yearly echocardiogram, a yearly pulmonary function testing, as well as some other tests as well. It's so important.
We had a question about NT-proBNP natriuretic peptide for screening. What do you have to say about that?
Yeah, so before I got involved with scleroderma research, I, used to dislike it if people would check an NT-proBNP in patients as a screening test. So, of course, we use it in people who have heart failure, who are getting hospitalized in heart failure. But the reason why we check both NT-proBNP and uric acid is because both are part of the DETECT algorithm, which is a screening tool that physicians use to determine your likelihood of whether or not you have pulmonary hypertension. And so both of those blood tests are part of our detection algorithm. And if they're high, then that triggers more testing.
What are the treatments? One question was, how do you treat it if you pick up early heart disease?
So one of the things that we encounter with scleroderma is that it can affect the heart in so many ways. And so it really depends on what your heart disease is. For high cholesterol and high blood pressure, we treat those just like we treat the normal non-scleroderma population. So patients that have scleroderma are treated exactly the same as patients who don't have scleroderma. We target a lower cholesterol. We make sure that their blood pressure is under control. Now, if we find pulmonary arterial hypertension, or if we find interstitial lung disease causing pulmonary hypertension, that does trigger very specific medications in a scleroderma population. And then in terms of diastolic dysfunction and some of the heart failure symptoms that we see, we also treat scleroderma patients exactly the same as we would treat a patient that didn't have scleroderma.
So we had a question asking, a scleroderma patient with elevated cholesterol, they have more risk for ongoing heart disease than a non-scleroderma patient with elevated cholesterol?
Yeah, so scleroderma is associated with some hardening of the arteries, and that can accelerate the rate of atherosclerosis or the rate of coronary artery disease. And so we are treating our patients exactly the same, where we kind of look at some of the rheumatologic conditions as risk enhancers. And so we want to make sure that we're jumping on the cholesterol early. We're doing everything that we can with diet and exercise at an earlier stage of disease so that it doesn't progress.
Got it. Thank you. What about I'm at a center that I didn't get screening. I have diffuse scleroderma. What kind of symptoms would make me concerned that maybe I'm developing heart disease or pulmonary hypertension?
So, it's important to distinguish between screening and detection. So if you have symptoms, we're doing these tests to detect what the problem is in your heart. If we're doing a screening test, we're just doing it on every single person to make sure that we're not missing something. And so if you have symptoms of shortness of breath, chest pain, difficulty with your exercise tolerance, like you notice, I used to be able to walk a mile and now I can barely walk a few steps, or you're having a hard time laying flat, that should all trigger you to go and seek medical attention from your doctor and to make sure that they know that you're having symptoms.
That's very helpful, that differentiation between screening and detection and the importance of responding to symptoms promptly. What about the role of exercise? Can it do anything to prevent the worsening of either interstitial lung disease or pulmonary hypertension?
So we think that exercise is great for the heart, as long as you're able, and it also can help recruit, areas of your lung that may have been a little bit sleepy before. And so exercise, as long as your doctor feels comfortable with you exercising, should be okay in all populations.
Great. What about what's the role of who gets that right heart cath? And I think we only have time for maybe a couple more questions.
Okay, sure. So the right heart cath is really dependent on what your resting echo cardiogram shows. Now, in some patients who have kind of intermediary signs, at our center, we do bicycle exercise stress tests, which helps us differentiate, are the pulmonary pressures going up when you exercise? Do you need more testing? Should you get a right heart cath? I see here in the chat that someone said that they had pulmonary hypertension with exercise, but not at rest. And so this is the type of scenario that we would watch really, really closely, because there have been studies that have shown that patients who have exercise pulmonary hypertension are at an increased risk for developing resting hypertension. So we would watch really, really closely to make sure that, we're staying on top of it, that we initiate medications as soon as possible.
Thank you. I think that may be all that we have time for. I hope you all did the evaluation, and thank you for attending this session. Now, you don't have to log out. The next one will just start automatically. And thank you so much, Dr. Mukherjee.
Yeah, of course.
Very informative talk.
I'll try to answer some of these questions that we didn't get to.
Thank you so much.
All right. Thank you.